Assistant Finance Director, Gareth Lewis, Assistant Head of Financial Services, and Susan Gauntlet, Assistant Head of Financial Accounting. So welcome. I'm pleased to see you here this morning. We have a number of apologies for absence. Pippa Britton, Helen Sweetland, Richard Clark, Louise Wright, Keith Sutcliffe, James Calvert, Rhiannon Jones and Sarah Aitken, and Gemma from the CHD is also unable to attend. Could I start on 1.3 in terms of declarations of interest, please? Are there any? No? Okay, to be noted. Thank you. The draft minutes of the meeting held on the 17th of May, are they correct? Yes. Thank you very much. The action log from the audit committee, is that okay? Yeah. Okay, you happy, Shelley? Fine. Counter fraud. To receive the counter fraud functional standard return declaration. I was going to say, I apologise. I'm sure I haven't read that paper. Anyway, can we start again? Oh goodness me. 2.1 to receive Wales Audit of Accounts report, please. Over to you.
Thank you, Chair. Good morning, everybody. It's like deja vu then from yesterday, Chair, with the agenda. Yeah, if I'd say we got 260 on the accounts, went through the audit committee yesterday and previously to the audit committee in May, some of the draft accounts. The report in front of us today is a very positive report, Chair. It's really pleasing to write this report and present it to yourselves today for approval. We do intend to issue an unqualified opinion on the accounts, although there is a regularity issue we've flagged up in the report and discussed with committee members over the last probably couple of months now in terms of clinicians' tax liabilities. It's a UK-wide issue, a Wales issue, and it applies to all health boards this year in terms of some of the issues that come out through that process. So it's not specific to yourselves, but it's featuring all 11 health boards accounts this year. In terms of the document, Chair, so I won't go through it in a great deal of detail as we went through it yesterday. It does set out the roles and responsibilities of us as auditors and yourselves as the health board. It does set the level of materiality that we work into, and I think it's important to sort of stress that we work to a level of 17 million. It's a high figure, but given the amounts going through the accounts, I think that's the relevant for us to make to yourselves. Although we do look at lower levels, things like the remuneration report, related parties, and so any ministerial directions, which is this clinician's tax liability. We touched on yesterday the impact of COVID over the last few years, Chair, in terms of how that process has worked, and I think it's worked. Although it's been a problem for us in the first year or so, I think we've got through that with the finance team. I think the relationships are really strong. I think it's really helped us meet the deadlines on all parts, and all the deadlines have been met this year. And the Auditor General will be signing off the accounts on Friday once the board hopefully approve them this morning. I think I did make the point yesterday. I think I've been 2 years of working virtually. It's probably thinking what we do next as the two teams, as some of the changes to those teams work their way through. It's probably built up a few relationships, which we'll sit down after this session, have a bit of a post-project learning session with Rob and the team and see where we go next into the next year's audit. But it's a really positive message, and it's allowed us to get to today with a sort of a few wishes to flag, but nothing really major to bring to your attention. On top of the proposed audit opinion that's set out in the appendices to the report, I say the only issue that we are flagging in the opinion is this clinician's tax liability. That's been sort of flagged in all of them. So again, it's not just yourselves. We have identified an uncorrected misstatement in the accounts for Nair and Bevan this year. And again, this is an all Wales issue. It's to do with district valuations that come in sort of later on in the day. Rather than putting those amendments through, it was agreed with Welsh Government and the DOF network not to do that, but to report them to the various of those charged with governance. It doesn't cause us an issue as the auditors. We'll still be signing those accounts off, and it just meant probably a bit less work at the end of the process for all sides, and the impact didn't really matter to the bottom line opinion. In terms of misstatements we've identified in the audit, Chair, I say, again, nothing that's affected the bottom line of the health board, which is really positive. There's a few classification issues we identified in Appendix 4. Again, nothing really to bring to your attention, given that there are just classification issues. So we just reported those as Appendix 4. And the two issues that we have identified which will need some work in the current year relates to asset existence and remuneration report. And again, it's thinking about how we do that differently with the health board going forward, and some work behind the scenes now before we get to sort of this time next year. I wasn't going to say much else, Chair, given the bit of good discussion on it yesterday in previous audit committee meetings. Happy to take any questions on the report, but as I said at the start, no, it's an unqualified opinion. If the board approve the accounts this morning, I'd be recommending the Auditor General to sign on Friday. And I suppose the last point is my thanks on record for Rob and the team for the way they've worked us, not just at year end, but throughout the audit process, Chair.
Thank you very much. That was a really helpful report, and I'm very pleased that you're working so constructively with the finance team, which is good to know. Are there any comments or questions? I know this has been gone through by the audit committee for some time. Yes, Rob?
Yeah, just to follow up in terms of Richard's comments, I want to thank the team for the quarterly report and working well with Richard's team. And a couple of points that we've picked up for improvement. We'll be getting a programme and an action plan and embedded in that immediately. Good.
Thank you very much. And this is the issue of the consultants' remuneration limits and etc. being taken up on a UK basis, are they not?
Yes.
Good. Thank you. If there are no further comments, could we then please go on to the approval and signing of the annual report and accounts?
I propose.
I was just going to, can I just?
Yeah.
Yeah, that's okay. Obviously, as you just heard, we held an audit committee yesterday when we looked at the draft annual report and accounts and associated documents and the audit of accounts report of external audit and the our letter of representation. I won't go through the particular issues that were raised at the meeting, which had just been through in relation to the pension and the misstatement. But we were very pleased to note that the Audit Wales were going to issue an unqualified opinion. Similarly, in relation to the head of internal audit report, which was an unqualified opinion, which again we were very pleased to see. Also, the fact that Audit Wales and management will be getting together in the autumn to do a debrief in terms of this process that they've gone through this year, so that they can learn from it. So on that basis, as chair of the committee, I would like to recommend to the board that it receives the accounts for 21-22 of the external audit, approves the annual report and annual accounts, which includes the performance report, the annual accountability report and the financial statements, approves the letter of representation and authorises the chair, chief executive and director of finance, procurement and value-based health to sign these documents where required. Thank you. Could I also just, on behalf of the committee, put my thanks forward, or our thanks forward, for all the hard work that internal audit and external audit have done, and particularly the finance team, but also the corporate governance team and Barney in particular for bringing all those documents together in a much more readable format. Let's put it that way.
Yes, I would endorse that. Thank you very much, Shelley, and thank you also for the really hard work that you've undertaken as the audit committee chair, as you step down from audit committee chair.
Not quite.
Nearly, because really you've done an absolutely excellent job in chairing that committee and creating an environment in which we can have very constructive conversations. So thank you, and I would reiterate your thanks to the auditors, internal and external, and the teams. So thank you very much. We're happy to endorse Shelley's recommendations.
Absolutely.
Yeah. Fine. Okay. Thank you. Right. If we can move to 2.3, to consider for approval and signing the annual report and accounts, starting with the performance report. Nicola?
Yeah, morning everyone. So I'm really pleased to present the performance report section of the annual report and accounts. It's a very comprehensive report trying to encompass the progress we've made across all elements, as well as some of the challenges we faced. And I think it's fair to say that 2021-22 was another challenging year in so many different ways, but one in which our staff continued to rise to the challenge as we continue to face various phases of the pandemic, at the same time as developing services and trying to restart many of our planned care services. As I said, the report's very comprehensive. It draws out progress against our annual plan. We didn't have to do an IMTP last year, we did an annual plan. And we took the opportunity in that annual plan to kind of change the way we set out our plan across the life course approach, supported by a number of key enablers. So if it's okay, Chair, I thought I will just pull out some key headlines across the breadth of the report, if that's helpful, just to draw out a couple of key progress areas, just to, you know, over and above what we would normally report through the performance report through the board. Is that okay? Would that be helpful?
Yes, thank you.
So in terms of the 5 key priority areas, there's a summary of some of the key headlines. Priority 1, which is giving every child the best start in life. I think the work we've done on Healthier Together online, given an online platform, to help new mothers access and pregnant mothers access support for their children has been a particular success in making sure people got access to good wellbeing support. Moving into priority 2, I think the work we've done around whole school approach to emotional and mental well-being and single point of access for some of our CAMHS patients has been hugely successful, and but has resulted in a doubling of referrals, which is good, but we've got to make sure we can now meet that demand. In terms of priority 3 and people living well, huge amounts of work across the breadth, but I wanted to particularly pick out the work around cancer services and commencing a rapid diagnostic service, which is again picking up patients at early stages of cancer, and I think is a really novel way forward for us to try to pick up people with cancer early on. Priority 4, in terms of looking after older people, I think the work we've done using some of the information tools we've now got and identifying the high-risk adult cohort across the different localities is a really different way of trying to identify patients and targeting them through a more proactive intervention, and there's some really good pilots have already happened in that area, and we know there's so much more we can do around that. And in terms of priority 5, in terms of the people dying well, I think the care after death team that was established and expanded has been hugely successful. Recently seen some staff stories, and it's hugely powerful, and the work they do in terms of supporting families when they've lost their loved ones has been a real added kind of quality service to what we offer to families, especially during the pandemic. So I thought I'd just pull out those. I think generally COVID response, there's quite a lot in the report, but ranging from the mass vaccination effort, which continued to be relentless through last year, and particularly at Christmas time, where we needed to vaccinate around 200,000 people over a period of 2 to 4 weeks as a result of Omicron, was nothing short of incredible, really, and demonstrated how the whole organisation came together to try to deliver that, and the agility our staff showed in trying to support that effort at a time when we were under significant pressure in urgent care. The challenges for infection prevention and control and the continued changing guidance and how we adapt that and make it safe in our organisations for patients and staff has been significant, as well as the whole testing programme, as well as the Test, Trace, Protect service. Huge amounts of work done in terms of supporting our population and our staff and our patients as they come into hospital. Briefly on primary care, huge demands on primary care, both in terms of GPs, dental services, optometry services, pharmacy services, and I think all of them have really stepped up and tried to look at, adapting the way they deliver services, trying to increase the capacity to meet demand. And there's a huge number of examples in the report of some different ways of working, and particularly therapy services I wanted to pull out, who I think have worked extremely flexibly over the last 12 months. And develop lots of different pathways to try to meet the needs that we've been facing. Just a few other areas I wanted to just pull out. Mental health in particular, I think, is really, despite all the pressures, and they've really suffered in many areas of staffing challenges, but the work they've done around crisis services has been quite, remarkable, really. And I think the Shared Lives programme in particular, which has seen quite a large number of patients who have avoided possibly an acute admission and gone to an approved home with people, and the feedback from that has been really quite exceptional, and I think that's an area we will continue to build on. The patient experience agenda, the work we've done on dementia, is really drawn out in the report. the meaningful activities, and also responding to, patient liaison officers in A&E recognising the pressures we've got at our ED departments and trying to put more patient liaison support into those to help people who are having to wait long periods of time, but at least getting some support. I've talked quite a lot around some of the secondary care services in the normal performance report, but we know, I've briefly mentioned cancer services, but a lot of proactive work going on around trying to expand for the future, investing in acute oncology. The satellite radiotherapy unit is progressing well for Neville Hall, and the YWF breast cancer business case being approved, despite, and trying to meet huge increased demands, particularly around colorectal, breast cancer referrals. So I think cancer services overall has been really trying to look at different ways of working under huge pressure. I think outpatients, trying to get that balance between virtual and face-to-face, and trying to not just go back to old ways of working and looking at new pathways and managing risk, and also contacting all the patients that we know are waiting for treatment. I know we've made a real concerted effort contacting the particular long waiters to make sure they're okay, whether they still need their treatment, and also is an opportunity to check on their clinical condition. And I know there's more of that we want to do as we go into this year. And just a final few points, I think, on the putting things right. We really have tried to put an effort into focus on early resolution, because we have seen increased complaints, particularly around waiting times and delays, communication during some of the visiting restrictions, and we really have tried to focus on working with families and patients around that. I think partnership-wise, there's been a huge effort between us and partners around the SCG, the TCG, the Community Care Group, and the RPB. We know there's lots more work we can do together, but I think we've got a really strong platform with which to build on. The comms team, I think the social media increase and continued activity we've done there, trying to promote as much of our work through social media, has been hugely successful. And I think the work we did around the Cardiff, working with Cardiff Bus, and we did a number of engagement events, was a real opportunity to get up a bit closer to the public when we were able to, and give people an opportunity to come and speak to us, which not only helped get some feedback about services, but also helped with recruitment as well. And that's something we want to build on. And we also did another version of the booklet to try and help people navigate their way around our system. And finally, around workforce, we've had some real successes with recruitment, despite huge challenges around sickness and absences linked to COVID and stress and burnout of staff. We have had some real success stories around recruitment, but our huge focus now is on well-being, and I think the People First plan that we've now put together really shows our commitment in investing in our workforce further. So there's much more in the report than what I've just said, but I could talk about it for hours, but I won't, you'll be pleased to know. But hopefully that just gives a flavour of some of the achievements we've done outside of what we normally report through the board in the standard performance report. Thank you, Chair.
Thank you, Nicola, for that comprehensive overview. Are there any questions at all? We shall, of course, be having a further discussion at our next meeting about the actual outcome of the annual plan as we intended. But that was a very helpful overview. And congratulations to everybody, because it's been an incredibly difficult year in which to maintain services, with many difficulties faced by a lot of people. And I'm very pleased personally to see that we are remaining in contact with people on waiting lists, so that they are not waiting thinking what's going to happen, but they know and have some assurance from us that they haven't been lost, and some idea of when they may or may not be treated. I think it's really important to maintain confidence in the system. Thank you again to all the staff for maintaining the services during this year. We are now facing an even more gruelling year, I think, in trying to pick up from where we left off 2 years ago. But nevertheless, I think we've made a very good start. So thank you to all of you. Okay. Where might we pass on then to part 2 of the annual report and accounts, the annual accountability report? Rani.
Thanks, Chair. So the purpose of the accountability report section has been designed to demonstrate the ways in which we are meeting our key accountability and reporting requirements. and the report is required to have 3 sections: the corporate governance report, which includes the director's report, the statement of accounting officers' responsibilities and a governance statement, then the remuneration and staff report, and a parliamentary accountability and audit report. The draft accountability report in its totality has been reviewed by Audit Wales and Welsh Government, in addition to review by the Audit Risk and Assurance Committee, and the final version presented to you today includes comments and feedback received. The annual governance statement reports the Head of Internal Audit opinion for 2021-22, and that has provided the board with reasonable assurance, and this was received by the Audit Risk and Assurance Committee yesterday. Pages 43 of the document, I think that's 160 of the board book, sets out the conclusion of the accountable officer, and for 2021-22 that confirms that the Health Board has remained on routine monitoring as part of NHS Wales escalation and intervention arrangements, and that the Health Board has continued to mature as an organisation. And whilst there are areas for strengthening, no significant internal control or governance issues have been identified. There is just one amendment I need to make following the meeting, Chair, and that is where the report refers to an internal audit report on network and information systems. The report refers to it as a providing limited assurance, but the Audit Risk and Assurance Committee received that final report yesterday and was able to take reasonable assurance in that regard. So we will make that one amendment following the meeting. Other than that, I wasn't going to go through the report in detail, but I'm happy to take comments or questions, Chair.
Thank you, Rani.
Thanks.
Are there any comments or questions? Are you happy about the annual accountability report?
I think that just to thank Rani really, who's been relatively new in post, and I think has done a terrific job in a short period of time, and say thank you to you and your team for all the hard work regarding keeping us all up to speed on everything.
Thank you very much. We'd reiterate that. She's keeping us on the straight and narrow, I have to say. So are we content to approve the annual accountability report as recommended by the Audit Committee? Yes?
Yes.
Thank you. Part 3, the annual financial statements. Rob?
Thanks, Anne. I've got the team on the call if there's any technical issues or points of detail anybody wants to pick up. But what I'd reflect on is the accounts have been prepared, obviously reviewed and audited by external audit. So we've got compliance there with the opinion already stated. In terms of an overview, the position remains that we've achieved our financial duties of revenue resource limit, capital resource limit. Our IMTP assigned for 3 years as previously reported, and our percentage of non-NHS bills paid have achieved that target as well. So I wasn't intending to go through the detail because there's quite a lot there, but as I say, the team are on the call. I want to thank those personally. If there's any questions, go through those.
Okay, thank you, Rob, and thank you to the team. It's really hard work, we know. Are there any questions? No? Are we happy then to approve the annual financial statements as recommended?
Yeah.
Yes, thank you.
Thank you.
Well, thank
you very much.
I think it's fair to say, Anne, that I mean it's been a very difficult time. I think throughout Wales for all sorts of reasons, particularly on the health side. And I think to get the sort of information we've got and the outcome that we've got, I think is a terrific achievement. And I think, you know, huge thanks to Rob and the team for again seeing us through very difficult times.
Thank you very much, Paul, and I would reiterate that. I wouldn't say we're unique in Wales, but we're certainly able to hold our heads up. Yeah, thank you. Might we move to 2, 3, 4, the approval of signing the letter of representation as included in the Audit Wales report. Richard?
Thank you, Chair. Yeah, the Underletter Rep comes alongside the Accounts Chair, set out what sort of some representation we need as auditors, and also addresses the uncorrected misstatement issue in terms of why that's not been put through, which we fully accept and on board with. So nothing further to say, Chair, apart from hopefully being approved.
Yeah.
Yep.
We're happy to approve for submission. In. Okay. Thank you very much. Thank you all of you for such a clear set of reports this year, which I think well sets out our position to enable us to go forward for this year and the next two. Could we go on to the items for discussion and start with the 6 goals for urgent and emergency care programme? You all know this has been directed by the Welsh Government. There have been a number of meetings about this, and there is a very, very clear, concise and tricky time frame attached to the action that is required. And a huge amount of work is going in to improving the situation and meeting the goals as outlined in this paper. Leanne.
Thanks very much for the opportunity to outline just a few key points really from the paper, not wishing to replay it. So just as a reminder, Welsh Government published sort of the policy document in February 22 and it was formally launched in April. The organisation was pretty well placed. We already had a pretty comprehensive urgent care transformation board in place at that time, chaired by Nick, and we were pretty well ahead, I think, of with a pretty comprehensive set of actions or improvement actions around our urgent care system. So in addition to that, we have been meeting on a weekly basis via the system leadership response to drive forward some of the improvement, given the focus and concern in particular around patient safety and I think the organisational will to do better for our patients. Albeit very important to note, this is a national problem. We are not unique, I think, in terms of some of the pressures that we're experiencing around our urgent and emergency care system, particularly set in the context of demand and some of the post-COVID conditions we find ourselves sort of dealing with. So the paper outlines, I guess, the progress that we've made thus far in our general approach, what our governance structure is, and importantly, just sort of I wanted to give you a flavour of some of the improvements that we expect to see over the next sort of 3 to 6 months in particular, recognising that there is a requirement for us to submit a more formal plan for the end of June to Welsh Government. One thing I think it's very, very important to reinforce is that I think the 6 goals sort of urgent and emergency care framework is really, really helpful, but it does absolutely represent the importance of a whole system response, a multi-organisational response, and sort of the importance of patients and third sector in undertaking that. And if we're to be successful in improving the system for our patients, then I think that needs to be sort of reinforced and remembered. Each of the individual goals have very specific potential sort of benefits and outcomes, but it is important, I think, sort of, and it does demonstrate the complexity and breadth of the improvement that we're trying to achieve through our urgent and emergency care system at the moment. And there are some examples in the paper of the things that we're focusing on and the priorities that we have. So in terms of the key actions that we've taken in recent months, obviously sort of April saw the formal launch of the paper. During May, we formalised our governance structure, and that is outlined in the paper as well. I think what was particularly welcome from certainly from a health board perspective was actually the recognition of requirement for leadership capacity to drive forward some of this improvement. And Welsh Government have funded specific leadership sort of posts within on a 3-year basis as well, which again is quite unusual, or has been sort of quite unusual, for clinical, managerial and analytical sort of support to drive forward and as I said, inject some leadership capacity into the system. What I think sort of in discussions that Chris and I have had on this, what was really important is that we added a 4th dimension to that triumvirate. We felt it was important that social care were represented in terms of the leadership model that we had, particularly ownership, the collaborative working, and we have made that representation to Welsh Government. We haven't formally had feedback on that, but the conversation we have had locally is regardless of Welsh Government feedback, we will proceed with that anyway. As I said, during June, we will finalise plans, and at the moment, the programme team are quite busy transferring across, I guess, sort of the improvement work that we were doing under the urgent care transformation board work into the 6 goals framework. The Overarching sort of governance structure is that we have a 6 goals programme board that is co-chaired whilst I'm the executive lead for this programme of work. Chris and I felt that it was very important that we demonstrated I guess sort of a joint approach and a commitment that we were both on the same page and driving forward this area of improvement for the benefit of our patients. So we co-chair that board importantly because we are all committed, I think, sort of to the same sort of outcomes and improvements. There is a monthly beat around the 6 goals programme board, but the expectation is that for each of the goal leads, there is a clinical and managerial lead. In the construct of that board, we have multi-professional, multi-organisational representation. So all key stakeholders are sat around the table to ensure that they are committed and we're working in collaboration to driving forward the improvement. And I think sort of when you start looking at the goals in particular and some of the schemes of work particularly that we have going on there, I think just to reinforce the complexity and scale of what we're trying to achieve here, I think is significant. Some of the conversation we have had with Welsh Government and some of the other health boards as well is that different health boards will be in different places in relation to sort of different priorities around urgent and emergency care. And I think that we do have an opportunity to focus on what's most important, set in the context of the overall sort of 6 goal framework that Welsh Government have set. So what? So the policy document is I think sort of a really helpful framework, but I think I just wanted to share with you a flavour, I guess, of some of the improvements that we expect to see in the coming months. And I think this is particularly important for us from a safety perspective ahead of winter. I think there are concerns around how we'll survive sort of another winter, but the programmes of work that we have and some of the ambitions that we've set ourselves that we believe are achievable, I think will help us stabilise that. So I'll give some examples if I can. So referenced in the paper is SDEC, same day emergency care. Previously used to be called ambulatory care in old currency, but Welsh Government have funded specifically £3.5 million worth of capital for a reconfiguration of estate at the Grange to help support that programme of work, and in addition to that have pump primed the service with about £1.5 million worth of revenue to support that. And just to give a flavour of, you know, what that will do for us. So at the moment, we assess out for those patients that are coming into our system, we assess out about 75% of patients that attend on an emergency admission perspective. The SDEC will be open and operational. We agreed the date in a workshop yesterday with effect from the 8th of August in the Grange. And we expect a range of in between 20 and 35 patients to be diverted away from our emergency assessment units and ED in the first instance. That is quite a modest, I think, start. When we ran some pilots around our surgical assessment unit in the Gwent ahead of the Grange opening, we were able to achieve about 85% sort of assessed out rate. So these are patients that are coming into our system that have rapid diagnostics, an assessment from a clinical team, and then diagnosis and treatment, and then sort of discharge, not requiring to be admitted into our hospital system. We, as I've said, that first phase will last for about 3 months, so August until sort of October time. Phase 2 will commence in November, and phase 3 will commence after Christmas. Albeit we expect as a result of the changes, even from phase 1, that will generate improvement across the whole system because of the capacity that releases for us. Overall, the expectation is that we could potentially deal with about 35% of our medical admissions sort of in a different way via this mechanism. Also referenced in the paper, and I think just to mention it sort of very briefly, there was a national risk summit in February 22, And I think in recognition of the extreme pressures that everyone was experiencing at that time, and a real concern and worry about needing to do something to change what was happening in the system sort of for our patients. So we had about 2 weeks to plan for it, which probably wasn't the best sort of lead-in time. And during the 2nd to the 16th of March, we undertook sort of a whole system sort of reset. We saw pretty modest improvements, albeit that the improvements were there and we were able to demonstrate that. What I think is important, and part of the reason it's included in the paper, is that some of the benefits that we saw and improvements we saw, I think, allow us to ensure that we understand the impact that some of the changes that we want to make. So consultant flow centre cover, for example, is alternative admission avoidance. We saw a 12% sort of improvement there, as an example. So as I've already outlined, we've got some pretty exciting plans around SDEC coming on board from August. In addition to that, we will be implementing a change of pathway around our ELGH criteria for patients being currently diverted to the Grange via ambulance and also GPs at the moment. We know in particular that our elderly frail patients don't get, because of the acuity, are currently being diverted to the Grange, and they can sometimes experience very long waits on the back of ambulance in particular, because of the acuity of those patients and the fact that we haven't got all the necessary teams and clinical expertise in the Grange for, as I said, sort of frailty type patients. Their experience is impacted by them being routed to the Grange, so there is a dedicated focus on changing that pathway. And really important to use that as an example of how we use patient stories and experience to drive the improvement that we need and to ensure that we're focusing on the right things. So in summary, before I open sort of to questions, I think sort of we welcome the framework. It's helpful, it's consistent. It also allows us to do some sort of learning across the whole of the system and the whole of Wales. Really important that Welsh Government are really important to sort of reinforce that. I think that we have made a very successful transition from our Urgent Care Transformation Board almost seamlessly into our 6 goals. It has almost allowed us to sort of pause, refresh and refocus where our priorities are. I can't overemphasise the importance of the whole system collaboration and response to this. Hugely, hugely important if we are to be successful in this and making improvements. We will continue to use our patient stories and experience to drive and ensure we're focusing on the right thing in relation to improvement. We will have much more granular plans with effect from the end of June, specific to 6 goals. And that will also then allow us to have some improvement profiles that I'm sure we will present to board at another time.
Thank you, Leah. A great deal of work has been undertaken in this respect, but it is an absolutely critical area for our patients and communities. It's a big priority for us, and it's also a big priority for the government. The Director General called a meeting of chairs and chief executives on system safety in relation to emergency care last week. So we are going to be monitored very, very closely indeed in terms of the agreements that were reached at that meeting. Has anybody any questions? Oh.
2 questions, or 3 questions really. The winter plan, last year's winter plan, have we had any feedback on that, or any learning from that, or what's any issues that come up? I'm not sure I picked up anything on the winter plan. There has
been a workshop on an all Wales level in relation to sort of learning that has sat sort of mainly, I think, in the planning domain. I don't know if Nick's got any sort of further update on that. I think we are pretty clear about what we need to put in place sort of for next winter, set in the context of the improvement plans that we have. But as I said, I know that there's been joint workshops from a regional partnership board perspective as well. Chris is nodding sort of on that to ensure that we're well prepared and organised ahead of next year.
What about last winter?
Chris will be able to.
Yeah, so just picking up on the work that was done in terms of the regional partnership board around the winter plan. So obviously there was very much around what were the actions the health board could take over the winter period, and also the ask and the work through the regional partnership board was around what actions local authority colleagues could take and we could do jointly. So that plan was implemented, and I know there's been a local workshop in terms of reviewing the learning from that, and I know we're bringing that back to, I think it's the next board meeting. I think we have an update on the learning from the winter plan, and also wants to take it into the regional partnership board to inform plans for, you know, as we move into the autumn for this year.
Yes.
So, and I guess one of the other bits around that was the whole sort of step closer to home model that was implemented over the winter and the various elements to that pathway. So health and local authority colleagues are actively working on reviewing that step closer to home pathway now in order for us to have some a paper coming to executive beginning of July.
That's good.
Thank you, Chris.
Thanks, Lee.
Did you want to add something to that?
I think Chris has probably covered off.
Okay.
We did discuss it briefly in the regional leadership group last week, which Chris and I attend with the directors of social services across the 5 local authorities. So the plan is to bring something through the regional partnership arrangements as well as obviously our own board. But you're quite right, it's really important that we learn from last winter, and I think it will be used to inform the regional plans going forwards for the next 5 years. So there's a plan called the RIP, or Regional Integrated Fund, which is how we work collectively and use our collective funding for the next 5 years. And it's really important that we take the learning from last winter in agreeing those priorities. Really important point that that's raised, Paul.
Could I just follow up? Because all the councils have come together as new councils now, so I'm just interested to know as to, has that been a good experience in terms of the recent conversations that have been had, because all the councils are new with new leaders in some cases?
So I think in terms of the regional partnership board, I mean, we've yet to meet with as a meeting of the regional partnership board with the new council members, but I mean, you'll be aware that we've gone through a period of local government elections, which I think has caused a bit of a hiatus, if you like, but nevertheless, we've still met as officers, so we've continued to meet with directors of social services to push forward some of the operational issues. But that's something that we'll need to pick up, I think, at the next regional partnership board.
And the other thing I have.
Hang on a sec, before you ask your next question. Shelley, did you want to add to that?
No, it's a general.
Okay, it's a different. Yeah. Nicola, did you want to add to that?
Yes, if I could please, Chair. And yeah, I completely agree. It's really important with the evaluation, and the planning team actually helped pull all the different strands of the winter plan together. I think it probably would be appropriate for us to, you know, help pull together that evaluation report, obviously picking up all the work the RPB will be doing, but also some of our internal plans and even some of the prevention issues such as flu, just to have that holistic report in readiness for our preparation for next year. So I think it's almost felt like we were still in winter, but I think it is timely now that we do. And I'm happy to pull that together through planning, where we pull the different strands of it.
Thank you very much indeed, Nicola. I think that's an absolutely excellent suggestion, because we do need a much more holistic approach to the evaluation of the parts that were ours and the parts that were from the councils or we do jointly. So I think we'd really welcome that. It would be very opportune to suggest that. Thank you. Okay,
Thank you.
Paul.
Right, so do you want to go in? In the papers that have been circulated, there's a very helpful on page 319, I think, go to the 400. The 2 parts really: what patients would like from the emergency care and what staff would like to from the emergency care. I just wanted to be sort of reassured that when the plans and whatever else has been organised, that actually that will be looked at, because it's sort of, it's not rocket science really what patients are looking for, but it is clear that if we can get those messages through to everybody so that everybody understands the system, then it will be much easier. And equally, I think with some of the comments we've had about, I think within Wales, about the stress and pressure that staff have had, it is important that we listen to staff voice as well. So just a reassurance on that basis, really.
I think they're really important points that you've made, Paul, and thank you for raising them. So, as I said, we use the patient story and experience to drive forward. You know, we regularly on the weekly SLR use an incident or something that's happened that week to inform, just to check that we've got the pathways right for those individual patients, that the outcome is as it should be for them. So there is definitely a piece of work for us to do to simplify our system. I think sort of people navigating our system, it is incredibly challenging because we have so many sort of alternatives. But it's most important, you know, we are absolutely clear that sort of right place, first time is really, really important sort of for our patients. So just to reassure you, that remains sort of front and centre in relation to the work that we're doing, and we have talked via sort of the 6 Goals Programme Board about almost a reference group, a stakeholder reference group, I think, to test some of that work as well for specific changes that we're looking to do. And the reason that the multi-professional, multi-organisational sort of, I think, leadership structure we've got in place in the 6 goals is so important is so that staff can and are able to voice their concerns and worries. We've got to take some, second on my worry list after sort of what happens to our patients is what happens to our staff, because if we look after our staff, generally speaking, the patients tend to be sort of well looked after also. They're under a huge amount of pressure at the moment in terms of the demand, which is why it's important that some of that leadership capacity and giving people the authority and support via the programme management sort of office to drive forward this is so important. And I think just a shout out, because Neil, part of Nicola's team and Simon have done a sterling job in organising us and providing support to busy clinical teams to help drive forward this improvement.
Thank you. Thank you.
Thank you. Can I just take up the issue of patients' experience? We have discussed it at this board recently because we were concerned that the systems through which patients could express how they feel about their care, whether it was good, whether it concerned them, you know, whatever they wished to say, was not as we would wish. Has action now been taken to overcome those difficulties?
So Ree had contacted Chris and myself about sort of a national platform called Civica, I think it's called, to allow us to capture that patient sort of experience measure. Both Chris and I have committed to that in terms of our operational sort of feedback, and that will be in place. I know Ree was very excited about it, and certainly we will be, because it will give us some systematic feedback in relation to the experience that patients are having. Good.
I'm really pleased to hear that. I'm sure the board's assured about that. Sarah?
Just to add to Paul's question around what staff want, there is a national workforce enabling group linked to the programme of work, which is looking nationally around a longer term plan for recruitment and retention, and also looking at models of education, training and workforce models which may support the work that we're doing locally, and enabling some of those points which staff have identified that they wish to be benefiting from as part of this.
Thank you.
Thank you. Shannon.
Yeah, thanks very much for the report, Leanne, and your presentation today. You mentioned in the report it's got phase 1, 2 and 3 and 4, and you mentioned the timelines for that, but you didn't. You said phase 3 would likely to be after Christmas, which I'm assuming would be January. But phase 4, when we planning for that to come back in?
I think that will be dependent on, so one of the things that we are doing sort of aligned to the different phases. So for example, if I use the SDEC at YYF as an example, we've got a value-based healthcare team working with the team around a robust evaluation. You know, the reality is our resources are so scarce, both in terms of workforce supply, but also obviously from a financial perspective, that we must ensure that the models that we have give us the greatest impact sort of for our patients. So whilst we've got definitive timelines around sort of phase 1 to 3, I expect phase 4 to be in sort of the new financial year, but we will sort of continue to review that. If we can bring that forward, we believe it's safe to do so, we will, because we are all very keen, I think, for improvement across the system sort of for our patients. But I think sort of there is a nervousness that we undertake sort of the robust evaluation to make sure that we are targeting sort of our resource where it needs to go.
Okay, thank you. Just one other question. So, in relation to the plan, you have to submit now by the end of the month. As Anne said, it's a huge amount of work, and this is really going to be monitored. I'm assuming as part of that, you will be required to put some measures in, those local measures. I mean, it might be national measures, but local measures. And what I wanted to check was those are going to be outcome based, and will they link into the framework that the planning team have developed already, the outcomes framework, so that as a board, we'll be able to monitor the work in this area along with the overall framework that we're going to be using for outcome measures, you know, as a board.
You'll be really pleased to hear that sort of the Nicola's planning team have been integral to sort of the development of the metrics for the 6 goals work and were previously for the urgent care transformation work, so that we've got one version of the truth. I think it's really important that we have a set of metrics that, as you say, sort of provides assurance in terms of the outcomes that for our patients and our staff as well, in fact. So Nicola's team have driven that forward for us and provide that information. We have that set of metrics already in place, established. Happy to share sort of more details of that sort of at another point, but I'm sure that we'll be coming back to report on progress against the plans, which will demonstrate that at another point in time.
Yeah, it'll form part of the performance report.
But can I just make an observation? I suppose going forward, particularly as we've now got we're going to have a committee that will look potentially, obviously, at the performance.
Yes.
I think from my perspective, whilst it's important that we measure performance against plans because we have to, I think it's that overall system, the whole, you know, the overview of where we are. I think is also, and that sometimes we're not quite joining everything up.
No.
I think also the impact of what we do. Better to you're more able to evaluate the performance overall, if you've got that overarching performance framework with the more detail underneath. If I can, so you might be doing something in a particular area that is really good, but it actually will impact on other performance areas as well. And I think we just need to get that all-encompassing approach, because I think then, you know, I think that will give us a more assurance than we currently have. Although obviously we get lots of assurance, but from different areas. Yeah,
I just don't know if it does help really, but we have worked really, really hard via the system leadership response meeting, the weekly meeting, to build that whole system view because of the interdependencies. So, and our not hope, because hope is not a plan, but our plan is that we will have a set of triggers or metrics, for example, that allow us to know that if something happens in one part of the system, we need to respond in another part to offset it. And if I use an example of, so for example, GP out of hours, staffing difficulties, sometimes happens, and that has an adverse impact in terms of attendances at ED sort of front door. So we cover that off so that everyone is cited on what happens. Our next step has to be to get to a more proactive management of that rather than reactive, which we have been. But we have put a lot of work into getting that whole system. And in fact, next piece of the jigsaw for us will be to join up some of the WAST data. In fact, I sent an escalation email to Wealth Government yesterday on that, because WAST have agreed to that, but haven't yet sort of initiated access to the system, so that we're doing exactly that, Shelley. It's really important.
Thank you so much.
Thank you.
Thank you.
Thank you very much.
Any further questions? No? Well, we look forward to receiving the plan at our July meeting, and thank you for that. Mike, we move on, please, to the planned care recovery, another part of the system which is under tension.
Yes, indeed, a hot topic nonetheless. So in April 22, Welsh Government published our programme for transforming and modernising planned care and reducing waiting lists in Wales. Nice snappy title. Paper that you have in front of you outlines sort of the organisational approach to sort of our planned care programme, and as you're aware, it's one of the key priorities, and I've got the joy of being sort of the exec lead on this. It is hugely ambitious, I think, in terms of the scale of the ask, but notwithstanding that clearly the concerns that are raised around the volumes of patients that are currently waiting across the whole of Wales for accessing their elective treatment. As I said, sort of the last sort of couple of years, obviously with COVID, there has been pretty much a hiatus in relation to elective activity, and what we had been able to achieve prior to COVID sort of has pretty much sort of been lost. There are some, I think, sort of key issues I just wanted to sort of share with you and flag really in relation to, in particular, the targets that have been set by Welsh Government and what we have committed to, and I guess sort of how challenging some of that is, and some of the plans that we have in place to sort of to mitigate that at the moment. So the targets in particular, and I think the messaging we are getting very loud and clear from Welsh Government in particular, is that there are some non-negotiable targets from a Welsh Government perspective in relation to sort of the strategy and policy that's been published. So the expectation, and there is an awful lot of pressure, and I'll share some of the conversations we've had more recently, is that by the end of December 22, no patient will have waited longer than 52 weeks for an outpatient appointment. And by the end of March 2023, no patients will have waited more than 2 years for their treatment. At the moment, I think just for you to be aware, we have submitted via our IMTP trajectories to Welsh Government that for the 52-week target, there'll be 9,300 patients at the end of March. For outpatients over 52 weeks, and for the 2-year treatment target, there'll be 1,600 patients. So there has not been a commitment from the Health Board for us to achieve those targets. At the point that we had submitted the IMTP, detailed demand and capacity work had been done sort of to undertake and to assess what was reasonable, and on the basis of the information that we had at that time, that those numbers were sort of committed. Just out of interest at the moment, sort of the current numbers of patients over 52 weeks, we've got 19,400 patients waiting over 52 weeks for outpatient appointments, and 6,500 patients just over waiting for treatment over 2 years. So the scale of the problem is enormous for us. I think in some respects, and again, sort of for the benefit of the board, we have, whilst those numbers don't feel like it, we have been very fortunate in comparison with some other health boards. We have examples across Wales of some surgeons not having operated for a number of years. That has a significant training and safety sort of issue. Some of those surgeons will need to retrain. The work that we have done in terms of our system configuration, the model of care that we have with the Royal Gwent in particular as our elective sort of centre, has meant that we've been able to make sort of better progress than sort of many other health boards. And there is a lot of work going on at the moment to understand and I guess sort of expectations being set that we get back to pre-COVID levels of activity to drive forward sort of improvement in the planned care sort of position. And again, just for context and for information, at the moment, comparative to 1920 information, we have a reduction. We are 13% below our outpatient activity, February and April 22 compared to 1920, and our treatment activity is in total about 27% down. That said, the recent announcement in terms of the de-escalation of COVID measures, at the moment the teams are undertaking quite significant pieces of work to reassess what the impact of a change in social distancing and some of the testing regimes in particular to sort of elective activity will do. And the expectation is that by the end of June, we will have an updated position in relation to that demand and capacity measure, and a much clearer view of where we expect to land against those aspirational targets from a Welsh Government perspective. We are not formally required to submit our plans to Welsh Government at this time. They are expecting us on the 17th of June, later this week, to resubmit our trajectories. But on the basis of the work we're doing on the de-escalation of COVID measures, that won't be complete until the end of June. And part of our IMTP resubmission to resubmit our minimum data set, we will do that at the end of Q1. So our trajectory update to Welsh Government at the end of this week will not say anything sort of different to that we've committed to from an IMTP perspective. There is, I'm going to call it an obsession because that's what it feels like at the moment from a Welsh Government perspective about what we're doing on planned care. And just to give a scale of, there will be a weekly all Wales meeting in relation to progress expectation from with Welsh Government on our performance against planned care, and then a much more detailed monthly meeting with them to go into sort of the detail. The reporting burden on this in particular is, I think, significant from an organisational sort of perspective. And I guess my concern around some of this is that it will distract people from the core job of getting on and doing the work of improvement and improving our core capacity in particular. We have, because it has felt, if I'm being very honest, that there's been a bit of a scattergun approach from Welsh Government in relation to requests coming in into lots of different areas. So in fact, for both 6 goals and planned care, we have put in place a central point of contact. We have a One Health Board email address that will coordinate all responses and requests for data so that we can do that in the least intrusive way possible and ensure that we're providing our stakeholders and sort of and partners sort of with the most sort of accurate information. So as I said, sort of there is a very heavy focus on this. Pressure is very, very clear to see at a national level, and that is manifesting itself down into a health board sort of understandably. That said, I think sort of the teams have been working really, really hard to generate sort of improvements in the system and to focus on some of the transformation in particular, because the reality is with the scale of the challenge that we've got, we are not going to deliver on this agenda without significant change and transformation in particular. So just wanted to tease out a few examples of some of the things that are happening at the moment and what our forward plans are then and what that will look like. So again, because of the configuration and the changes as a result of sort of clinical futures, we've been quite lucky that we have a state compared to sort of other parts of Wales. We have had vacant theatres and if I use the example of the old cath labs in the Gwent, they have been converted into an outpatient day case facility. So this is a really good example of where patients may have been done in a standard day case facility previously. We can do them in an outpatient setting. And one of the schemes that we're currently looking at is undertaking one-stop carpal tunnel clinics there. And again, if we use that example, one stop means that patient experience is improved because they're only coming for one visit. It condenses the time of the pathway, but more importantly, sort of in addition to that, previously these patients would have been done potentially in a laminar flow theatre with a significant theatre team around them. That won't be the case anymore. There'll be a reduced workforce sort of attached to that. So I use that as an example of some of the changes that we're making from a transformation perspective. We have plans around dermatology and max vax in oral surgery as well. So we've got a growing list of people wanting to access that sort of facility. Some other examples, outpatient transformations, really important that the transformation is owned by the clinical sort of teams and in pathway work and in conjunction with primary care in particular. But orthopaedics, you'll be unsurprised to hear, is one of our most significant pressure areas from a planned care or sort of RTT perspective. And we've recently had agreement from the clinical teams that all of our patients from following major joint surgery will move to patient-initiated follow-up, which is again another target from Welsh Government. That is really, really important for us. So potentially we're still waiting on some modelling work, but that may release up to 40% of our follow-up waiting list in orthopaedics. So there are some very significant changes that we're working hard to generate to free up capacity to treat new patients and to improve the situation that we're currently sort of experiencing. And some other examples, we've got audiology, if we look sort of for some of the more therapeutic sort of intervention. Previously, a patient would have come in for 3 appointments, and as a result of some of the changes we've made through COVID and remote programming of aids, we've been able to move to hearing aids. We've been able to move into a one-stop sort of appointment and then remote access for patients. So there are plans in place in terms of outpatient transformation for all of the clinical areas now that are driving forward sort of this transformation and a commitment from each of the clinical leads in those areas in conjunction with the NCN leads, I think, to drive forward some of the improvement work. Final thing I guess I wanted to say on planned care, it has, because of the hiatus, we felt it was quite important to bring together the clinical teams across the whole of the system, in particular secondary and primary care together, because our concern is that some of these patients will bounce around the system looking to access support. And we have a launch of the planned care, our own planned care programme set in the context of the national sort of strategy this Friday. And our plan is that we will have 5 key priority areas that we will focus on as part of that. We will use the launch on Friday to inform more detailed plans that then will inform the improvement trajectory and what we feel able to realistically commit to. And I think it is really important that we are realistic in our assessment, not least because of the importance of being honest with our patients about sort of how and how long they are likely to wait sort of for their treatment. The final thing I guess I just wanted to flag is that we do have, as a result of the trajectory and the activity we're currently doing, a significant amount of additional work within each of the areas, in particular waiting list initiatives and backfill, for example, that we currently don't have financial sort of coverage for. And that runs into multi-million pounds. There's a piece of work to be done, I think, to assess that, and we're having conversations about that, in spite of the fact that there is a view that Welsh Government has given us money on planned care, and that should be covered off. But I flag that because I think there is a financial risk around the level of activity that we're currently doing. Notwithstanding, there is plenty more that we can do within our own core delivery mechanisms, I think, to improve that. And I think, as I said, the COVID de-escalation measures will help with that. So, in summary, hugely challenging agenda, mainly because of the volume of patients that we need to get to. Very important that we only commit to what we feel able to deliver on, most importantly for our patients, but also our staff as well. But encouraged that we are in a better place compared to many others in Wales, albeit there is a real will from the clinical teams to do better still to improve the situation.
Thank you, Leanne. That was very comprehensive. And perhaps you could, Rob, please just elaborate on the financial situation in respect to planned care recovery.
Yeah, so in terms of the resources we've received from Welsh Government, there's an additional recurrent fund we had as part of the MTP and the allocation letter this year, which, if you recall, we designed our investment profile around sustainability. So an element of that would have obviously supported some further investment in planned care. Where we find ourselves at the moment is obviously following up on what Leanne said, is to actually generate enough service capacity to deliver the targets the Welsh Government are aiming for us to achieve will actually put pressure on our financials. It's an area of work that, just to repeat what Leanne said, really, that we're looking at through transformation and redesign, and also with the implications of COVID easing. That's another factor. However, we do currently continue to see acute pressures across the system having a big impact on us. So at the moment, we're working through the implications of transformation and opportunities around there. There will be pressures on the organisation, and in the mix of our whole service portfolio, there may be a need to consider what we prioritise as part of a board review, following probably a review over the next month or two of our current performance and plans for delivery for the year.
Okay. So we'll discuss this. You'll give us an update at the next meeting, but we'll discuss it in a more cogent way following that. Thank you. Are there any questions and comments? Paul?
I just wondered whether you'd looked at the report which had come from the BBC to do with the Nuffield Trust, because Nuffield Trust is an assessment, and it looks as if the average length of stay in other parts of the UK was sort of 4 days in hospital, whereas in Wales, I'm not sure about, and I remember 7 days. And I wondered if we got an average length of stay at all, or has that been reducing, or where are we with regards to that?
We have seen, so that relates to our, in the main, sort of our emergency and urgent care sort of position. We are working hard on some of the improvements in terms of length of stay specific to planned care, as an example. And one of the examples I would give of that is, so last week we did our first, I know it's been done in other parts of the UK, but it is a first for us sort of here, our first paediatric day case tonsillectomy. Previously, because of the risk of bleeding, those patients would have been done on an inpatient basis. And in addition to that, there are a series, I think, just of getting it right first time reviews for individual specialties. So we've had the formal report from orthopaedics, with the expectation is that 90% of our treatments will be done on a day case basis. So there are, we know our length of stay is not where we would want it to be. We have, on our urgent and emergency care perspective, our +7 days and +21 days is of worry and concern, and hence the programme of work on 6 goals, a particular focus on our discharge planning sort of processes. But in relation to the planned care system, the outpatient day case is a good example of that. You know, we need to move from inpatient to day case, on day case to outpatient day case, to try and take some pressure off the system and our resources. And actually, we know that generally speaking, that's also better for our patients. So there will be targeted areas, certainly from a planned care perspective, where we will be tracking length of stay specifically.
Just interesting to see what the figures were. Thank you.
Glenn?
Probably just worth saying as well on the Nuffield Trust report that was published, that both Welsh Government and the Welsh NHS confirmed how the performance measures are actually recorded in each of the 4 devolved nations, so not just England and Wales, but the four devolved nations, because some of them differ. And I think it's probably important for people to understand, you know, what is real performance difference and what is around how you count. So I think Welsh Government are planning to issue a briefing in the near future, but also the Welsh NHS Confederation are doing a fairly big piece of work on this as well.
Okay, thank you. Very helpful.
I wouldn't really imagine that a length of stay could be calculated in a different way, because you're either in or you're not. But anyway, Nicola.
Yeah, thanks. It was just picking up on the planned care report that Leanne's given there, and just some of the discussions we've had at directors of planning and regionally. I think, you know, in some ways, I think a target helps focus the mind, and I think all of us would support trying to reduce the numbers of patients waiting that long. But I think, as Leanne said, we're quite keen to not give a commitment to something unless we've got a level of confidence we can deliver it, albeit we recognise the kind of non-negotiable nature with which it's being set. I think the biggest challenge we'll have is around how we balance the risk prioritisation that we've been working on in terms of urgent and the Royal College kind of categorisation and so on versus the long waiters. And that's going to be a real challenge for us, I think, alongside then the financial challenges in terms of, you know, what we prioritise first. Some of the discussions we've been having regionally, and this won't apply to necessarily all specialties, but you know, are there specific initiatives that we can work together on and work with Welsh Government in terms of supporting us where it's specifically commissioned for the long waiting patients, which then helps us kind of target the groups in separate ways. So that's something we are looking at, which might help that challenge, I think, with the operational teams around risk, urgency versus long waiters. But and also just on the point around, obviously, given the importance of the targets, there is a risk of kind of the micromanagement approach, and we've fed that back to, we've had some really constructive discussions with Welsh Government colleagues around how do we get the right balance of reporting and assurance to allowing us to get on and actually do the doing and not spend too much time reporting with unvalidated data. So those conversations are happening as well to try to make sure we strike the right balance on that. So just thought I'd share some of those conversations.
Thank you. Yeah, thank you, Nicola.
Just to, I think, add on that point, the last conversation that I had with the National Director for Plan Care sort of recovery on this was actually maybe one of the models that you could put in place as a business partner model. So place someone from the delivery unit in the health board to act as the point of contact and the report sort of and undertake the reporting function, so that they get to know us, they're embedded to try and take that burden off, and they didn't seem adverse to that, albeit sort of, well, I'll follow up on that conversation, but I think they're so desperate for improvement. I think that they are listening to sort of suggestions about how we might be able to do this sort of better.
Good, thank you. I think I'd pursue that, Leanne, quite frankly. Are there any further questions? Obviously, we will receive the Plan Care programme at our next meeting, but if we do have to resubmit by the end of the month, how confident can we be at the moment that we can achieve what, if that's the deadline? I think it's important that we have got to have confidence in what goes in that will be achievable, and where things aren't achievable, we have to be quite clear about what and why not. I really do think we've got to be honest, absolutely honest. Nicola?
Yeah, just picking up that point, Chair, because the IMTP guidance and the process we put in place is that once Q1 is completed, we would review our position and we would update our MDSs on a quarterly basis, which will then get signed off by the board before submission. So the July board was intended to have, you know, a review of Q1 plus then the predictions for future quarters, which you then sign off. Obviously, the speed of which the Plan Care programme has come out and the new targets and the need for trajectories quicker, which we fed back as well, is then goes against the governance process that we've put in place. So obviously, as Leanne said, we are planning to resubmit the trajectories we've got at the minute, which is consistent with our process. But I think if we're in a position to submit trajectories in advance of the board, we might need to look at how we can just make sure we brief the board in advance of that, given the importance of, like you said, that confidence of delivery. So we need to just consider that as we're in a position to change them.
Thank you, Nicola. Leanne?
Yeah, just very quickly, because at the moment Welsh Government are circulating some sort of documentation that suggests on a very simple trajectory perspective that Anira and Bevan are the only health board that are likely to deliver on this target. They have risk assessed us as green. But what they do not know is that information in terms of includes a significant amount of sort of one-off validation. So we have been very clear that we are holding to the IMTP trajectories, which does not commit us to delivering on that target. We are fully committed to the programme of improvement work, but we can't sign up to those sort of numbers without doing that detailed sort of piece of work, which, as Nick has said, will follow by the process that we've already outlined.
Thank you. Thanks for that assurance. Anything further on planned care? We will be returning to this in about a month. Okay, thank you. Is there any other business before I close the meeting? If not, the next meeting will be on one of our usual meetings on Wednesday, the 27th of July, and I'd like to thank you all for your contributions this morning.